Good morning and welcome to the 6th Annual AAU and ICSU Conference for 2021. It is my distinct pleasure to host you for this session on the important topic of intermittent pneumatic compression as a mechanical prophylaxis approach in the prevention of deep vein thrombosis. I am your host, Quentin, the Senior Product Manager for VTE at ARJO, South Africa. When we are looking at venous thromboembolism, we need to understand that VTE or venous thromboembolism is the umbrella term normally referring to a DVT and a PE, whereby the acronym DVT stands for deep vein thrombosis or a blood clot, and PE is the acronym for a pulmonary embolism. But venous thromboembolism disease also has comorbidities attached to it or related complications. Now, a venous thromboembolic disease is worldwide known as the silent killer epidemic, and the reasons for it having this tag is due to the fact that most often clinical signs of a blood clot are absent, and symptoms may be very confusing. And also, we cannot accurately predict who will get a VTE and who will not. The signs and symptoms of a deep vein thrombosis normally manifests itself in the lower extremity in regards to severe leg pain, swelling, tenderness of the surrounding area, warmth, and discoloration or redness. Symptoms also depends upon the size and the extent of the clot. Now, the comorbidities in regards to a deep vein thrombosis is post-thrombotic syndrome or PTS. Now, it is estimated that around 1/3 of patients with a DVT will develop a post-thrombotic syndrome, therefore suffering swelling and severe pain. 25% of patients will develop chronic ulceration, which is associated with substantial ongoing treatment cost. The estimated cost per patient episode of post-thrombotic syndrome is estimated to be at least $5,000. The estimated average cost for a venous leg ulcer per wound is estimated to be at $8,000. The clinical studies also estimate that at least 93% of all venous leg ulcers will only heal in 12 months' time, and 7% will remain unhealed after a 5-year period, and that at least 70% of patients experience a recurrence within 3 months. Therefore, it is quite clear that once a patient has developed a deep vein thrombosis, the treatment and care plan will not only resolve around the treatment of the blood clot itself, but also that the post-thrombotic syndrome associated with this dreaded disease will become a part of the treatment and care plan of the patient for the rest of their life. When we are looking at the global and the local burden in regards to VTE, we need to understand very clearly from the beginning that VTE is the most common cause of preventable death in hospitalized patients. It needs to be understood that venous thromboembolism is a preventable disease, and the cost of treating a preventable venous thromboembolism has been estimated to be at $14.2 billion per year, and this cost is expected to rise to $39.3 billion as the cost and the subsequent incidence and prevalence of this disease keeps on rising year on year. Up to $19.1 billion is spent each year in the treatment of long-term complications following VTE. And I would like to bring your attention to the fact that at least $19 billion is spent each year in the treatment of long-term complications following VTE. And this is not only speaking to the treatment of a developed deep vein thrombosis, but also to the comorbidities in regards to post-thrombotic syndrome, which is venous leg ulcers, that is making up quite a big chunk in regards to the treatment of the long-term complications. Therefore, it is really important to be cognizant of the fact that all of that cost and the impact on the quality of life of the patient can be avoided when proper protocol and risk assessments are in place to assist you, the clinician, as well as the healthcare facility in preventing venous thromboembolism from developing in the first place. So why? Why is VTE so important? With healthcare demand at unprecedented levels and budgets struggling to keep pace, attention is increasingly focused upon adverse clinical events. Of particular interest are incidents such as VTE that are common, have a high economic and humanitarian cost, and are largely considered to be preventable. Globally, when we are looking globally at VT events and the subsequent morbidity and mortality rates, it is estimated that at least 10 million of hospitalized adults will be diagnosed with a DVT. And of that, at least on average 500,000 will result in a mortality rate. 25% sudden death as the first symptom, and 10% will die within the first month of diagnosis. 33% will have a recurrence within 10 years. And therefore, looking at this horrific statistics, we can yet again highlight and see why VTE is such a high burden on healthcare systems globally. Looking at the USA's own VTE events in regards to mortality and morbidity, it is estimated that at least 900,000 Americans will be affected in developing a DVT on an annual basis. And from this 900,000 that will be expected to develop a hospital-acquired DVT, 100,000 of them will result in sudden death. It is also expected that the rate of VTE will double by 2025. Now, what is the disease burden of venous thromboembolism on the African continent? Unfortunately, we have largely an unknown paucity of data in this regard, but there is quite a lot of emerging evidence that shows its increasing impact on the maternal mortality rates, specifically in regards to postpartum C-sections, in hospital patient mortality and morbidities, post-hospital admission mortality and morbidity, COVID-19 related mortality and morbidities, ICU-related mortality and morbidity, HIV/AIDS, and TB. It is quite important to understand that venous thromboembolic disease is prevalent in almost all spheres of surgical and non-surgical risk populations. And therefore, COVID-19, our current epidemic that we are trying to mitigate the risk of infection, is also highlighting the fact that hypercoagulability and developing a deep vein thrombosis is quite high in that risk population. Africa VTE events, it is estimated that at least 1/4 of patients at risk for a VTE in Africa are not receiving any adequate prophylaxis. It is also estimated that at least 7% of this risk is an in-hospital acquired prevalence and incidence factor. 37% will be suspected pulmonary embolism cases, and at least 400,000 of those cases will be morbidity cases. With these shown stats, it is quite clear that it's not only a global impact, a USA impact, but also impacting our African continent quite. Now, what is venous thromboembolism's risk factors? What causes a DVT risk? What allows that risk to come to the fore and having our patients admitted to hospital actually acquiring a blood clot? The most popular and most simple method of determining whether a patient or a patient group will be at high risk of developing a deep vein thrombosis is to revert back to Virchow's triad. Now, Virchow's triad is a very simplistic but a very accurate model in regards to determining the risk for a patient of developing a deep vein thrombosis. And Virchow's triad has 3 pillars attached to it. So according to Virchow's triad, venous stasis is one of the pillars that determines that you will develop a deep vein thrombosis or a blood clot. Hypercoagulation is the second pillar in regards to you having a high risk of developing a blood clot, and also vessel injury as the third and final pillar in regards to you being at risk of developing a blood clot or a deep vein thrombosis. Now, when we are looking at venous stasis as the first pillar, venous stasis is normally when the circulatory system is decreasing quite significantly, and the decrease of the circulatory system actually results then in venous stasis. Now, how does venous stasis occur? Venous stasis normally occurs during surgical procedures that is longer than 30 minutes, also assisted by immobility, whereby the calf muscles are inactive and cannot assist with the compression of the deep veins in augmenting the blood flow. Obesity, due to the fact that obese patients are less likely to be mobile. Sepsis is an inflammatory state that also assists and compounds the factors of venous stasis. Lower extremity edema, varicose veins, paralysis or stroke, patient groups age 40 and above, pregnancy or postpartum C-section specifically, estrogen therapy, hormone replacement therapies, trauma, muscle relaxants during surgery, and heart or respiratory failure are all risk factors that is increasing venous stasis to start setting in. The second leg of Virchow's triad is in regards to hypercoagulation. Now, hypercoagulation in effect means that the blood's viscosity is changing to become more thicker and less fluid. Thereby, the factors that influence hypercoagulation in the deep veins is thrombophilia, dehydration, malignancies, stroke, pregnancy, yet again, hormone replacement therapies, inflammatory diseases, and also compounded yet again by surgical procedures that is longer than 30 minutes. Vessel injury. Vessel injury is the third and the last pillar in regards to Virchow's triad, and normally the factors involved with vessel injury will be history of phlebitis in regards to trauma, venous stasis, varicose veins, but also quite a lot of invasive procedures where we are inserting arterial or any venous lines. And then during surgery, fibrinolytic shutdown normally starts setting in after 72 hours. This is a very brief look at the 3 pillars that will assist you as a clinician and as a facility to be able to determine when a patient will be at high risk of developing a deep vein thrombosis. But having a look at these 3 pillars of Virchow's triad, it is quite clearly to understand that once a patient is admitted to hospital, the risk of developing a hospital-acquired DVT or blood clot increases quite significantly due to the fact that venous stasis will set in once that patient is admitted to hospital due to surgery, and then also to the immobility factor for being bedridden for an extended period of time. Hypercoagulation can also be ticked off due to the surgical procedure being longer than 30 hours, any history of trauma, etc. And then vessel injury. Vessel injury goes without saying that surgical procedure is the biggest compounding factor when it comes to vessel injury that assists the blood clotting factors to be activated. Now, also incredibly important to understand is not only the 3 risk factors that put a patient at high risk of developing a deep vein thrombosis, but we also need to have an understanding of who is then at risk of developing a deep vein thrombosis. It is stated that when 1 or more risk factors are present, anybody from a new mother to a frail elder with reduced mobility is at risk of developing a VTE. Surgery itself causes the greatest increase in risk of developing a DVT because the anesthetic will be linked directly to the hypercoagulation state of the deep veins. Muscle relaxants will assist and compound the venous stasis factor, and surgical intervention will compound the vessel and the tissue injury. It is now clear that non-surgical patients are also at high risk of VTE. Not only surgical patients, but surgical patients, non-surgical patients as well. When we are looking at high-risk groups such as critical care, cancer, obstetrics, pediatrics, and strokes, it has been proven over and over that these patient population groups are also at a very high risk of developing a blood clot or a deep vein thrombosis. It is expected that at least more than 50% of hospital patients will be at risk of acquiring or developing a deep vein thrombosis, and that at least less than 50% of these high-risk patient groups will be getting the recommended prophylaxis. Sevenfold increase in VTE incidence for patients with a malignancy in regards to the high-risk population groups. Hospitalization is therefore the major risk factor in regards to developing a blood clot or a deep vein thrombosis. It is estimated that at least 1 in 20 of the population will have a VTE episode during their lifetime. 50% of these will have been hospitalized in the previous 8 weeks. To highlight again the message from this session, it is incredibly important to understand that VTE is the most common cause of preventable death in hospitalized patients. Patients with mobility challenges have the highest risk of developing a VTE. Now, when we are looking at VTE, the disease, and how we are stratifying the prevention of VTE, we are normally looking at 2 types of prophylactic interventions, whereby the one is pharmacological prophylaxis as an intervention method, and then mechanical prophylaxis as a prophylactic intervention. Pharmacological prophylaxis normally refers to any of your direct oral anticoagulant tablets or pills that you take for an extended period of time to regulate and to mitigate the risk of acquiring a DVT or managing the treatment of DVT, and then also subsequently direct subcutaneous injections. When we are looking at mechanical prophylaxis as a prophylactic intervention, we can normally subdivide that into any active compression devices and then static compression devices. Active compression devices normally refers to intermittent pneumatic compression devices, whereby you have a device that's got a compressor. That compressor inflates and deflates cuffs, garments, or sleeves as they are known, which is normally applied to the calf, the foot, or calf and thigh of a patient's leg, subsequently providing additional pressure to the calf muscles, and that then assists in emptying or augmenting the blood flow of the deep veins. Whereby static compression normally refers to your graduated compression stockings that provides a circumferential compression most of the time without any active compression that will be applied by that type of mechanical method. Now, when we are looking at pharmacological strategies as a intervention or a prophylaxis method, we need to have an understanding that referring back to virtuous triad, whereby the high risk factors in regards to patients developing deep vein thrombosis will be venous stasis, vessel injury, and hypercoagulation. Pharmacological intervention only directly addresses hypercoagulation of the 3 pillars. Complications. There's always a lot of complications to be made aware of in regards to pharmacological interventions, even though pharmacological interventions are the gold standard and the most utilized prevention and treatment intervention when it comes to deep vein thrombosis. But complications that we need to bring to your attention is the fact that pharmacological interventions normally have a very high hemorrhage risk. Venous stasis is obviously not addressed. There's always the risk of maladministration, and anticoagulants remain one of the leading causes of medication errors and subsequently adverse events. The combination of a vulnerable patient population and a powerful pharmacological action rank amongst the highest risks in prescription drug therapy. Now, patient-specific factors that always increases bleeding risk is normally broken down into significant renal impairments, current active major bleedings, recent clinically significant bleedings, inherited or acquired bleeding disorders, severe platelet function disorder, recent central nervous system bleeding, recent major surgery with a high risk of bleeding, active peptic ulcers or active ulcerative GI diseases, and then concomitant use of medications that also affect clotting, surgical procedures with high bleeding risks such as head and neck surgery, neurosurgery, and the recent gastrointestinal bleeding that is also having a very high risk population group, and uncontrolled systolic hypertension. Now, this is just the broad spectrum in regards to patient-specific factors that might increase the bleeding risk in patients, whereby pharmacological prophylaxis are contraindicated. And having brought that to your attention, I would like then to introduce you to the alternative to pharmacological prophylaxis where they are contraindicated or caution for use are raised, is to introduce you to mechanical prophylaxis as an alternative intervention. Now, mechanical prophylaxis, as you know, are broken down into two subcategories, whereby we have active compression, which is known as IPC, and static compression, which is known as graduated compression stockings. Now, I will be giving you a little bit more information in regards to intermittent pneumatic compression or IPC, how this intervention works, and just how advantageous this specific intervention is in regards to the prevention of deep vein thrombosis. Now, IPC or intermittent pneumatic compression is commonly referred to as scarf compression or just active compression. So how does mechanical prophylaxis in regards to intermittent pneumatic compression prevents deep vein thrombosis? Referring back again to Virchow's triad, it is one of the only modalities that is actually addressing venous stasis and also hypercoagulation, whereby pharmacological prophylaxis only addresses hypercoagulation. So what is the impact of IPC on Virchow's triad? Yet again, this is the only modality managing two of the risk factors. It is non-invasive and mimics the natural activity of the calf muscle pump. It increases blood flow velocity in the deep veins, thereby reducing stasis and flushing valve pockets where thrombi originate. It addresses venous stasis. The mechanical effects of increasing blood flow also apply a shear and strain on the endothelial lining of the veins and the arteries. Biochemical mediators are released, which enhances fibrinolysis, platelet disaggregation, and vasodilation, which addresses hypercoagulation. So, intermittent pneumatic compression. What is the mechanism of action? All IPC systems have a single common purpose: to propel blood from the deeper veins through intermittent inflation and deflation of a garment, a sleeve, or a cuff. It mimics the action of the calf muscle pump on natural ambulation, increasing the circulation of blood in the deep veins of the legs. It is a safe and effective standalone modality for patients at high risk of bleeding, or as a combined therapy for patients at high risk of VTE. When we are looking at the compression profile of intermittent pneumatic compression, it is normally divided into either a uniform compression profile or a sequential compression profile. A uniform compression profile refers to a single air chamber of a calf that is inflated and applies a uniform pressure to the limb. A sequential compression profile normally refers to a series of interconnected air chambers, which is 3, that inflates in turn in a proximal direction from the foot. the uniform garment and the sequential. What does these two compression profiles have in common? That there is absolutely no clinical difference. Even though we do have two types of compression profiles, it is stated that in effect there is no clinical difference at all. IPC is an effective prophylaxis, irrespective of mode of action. Neither the garment nor the type of compression makes a significant difference to hematological outcomes. Active compression in regards to intermittent pneumatic compression is the reversal of venous stasis, which is the key prevention factor. And this has also been subjected to a number of comparative laboratory tests and consistently demonstrated favorable results. At the end of the day, IPC is a method of moving blood within the lower extremities towards the heart by a systematic inflation and deflation of garments or the cuffs. Inflation of the garment squeezes the blood from the underlying deep vein and displaces it proximately. On deflation of the cuff, the veins will refill. IPC therefore simulates the natural calf muscle pump. In regards, it is a natural remedy or a natural prevention modality whereby it is only simulating the natural calf muscle pump. The hematological effects of IPC is not always well known, and therefore I would like to bring your attention to the fact that IPC's mechanical force and the compression that it produces on the deep veins are producing a shear and strain effect on the endothelial lining of the deep veins. Therefore, this leads to the release of key chemical mediators from the endothelial cells that is lining these deep veins. Now, this is all assisting the natural chemical processes in regards to fibrinolytic effect, antithrombotic effect, and other effects in regards to nitric oxide vessel dilatation and platelet disaggregation. What's the effects of IPC in preventing DVT? Well, it's threefold. IPC affects the antithrombotic processes, the vasodilatory processes, and also the profibrinolytic effects and processes in regards to breaking down blood clots. Recommendations: we are recommending as a supplier and manufacturing of IPC that it should be worn for 75% of the time or a minimum of 18 hours per day. The success of therapy is dependent on patient compliance, comfort, and nursing intervention. Contraindications to IPC as a modality and treatment is severe arteriosclerosis or other ischemic vascular diseases, lower limb wounds, recent skin grafts, dermatitis or any untreated infected leg wounds, gangrene, severe congestive cardiac failure, or any known or suspected DVT or PE. VTE prevention protocols as a global perspective, we can be well assured that there's quite a lot of international and national guidelines to assist you, the facility, and you, the clinician, in having a very good understanding of just how IPC should be utilized as a prevention modality, and therefore also making specific recommendations based on risk. And the highest risk in population groups is normally in regards to cardiac surgery, vascular surgery, day surgery, total hip replacements, total knee replacements, malignancies, and any other orthopedic surgeries. All patients must always be risk assessed because DVT is a hospital-acquired disease. All facilities should have a prophylaxis protocol and event register. Protocols need active implementation, and awareness alone does not change practice. I would like to thank you for the time that you have afforded me today to provide you with a little bit of better understanding in regards to intermittent pneumatic compression and how that can be your alternative prophylaxis modality and also an adjacent prophylaxis modality when it comes to the prevention of deep vein thrombosis. Should you have any questions for me, I am quite excited to answer any one of them. or should you require more information in regards to the Flowtron active compression system that RJO has available to assist you and your facilities in regards to preventing hospital-acquired deep vein thrombosis, please do reach out and I will assist you wherever possible. Thank you for having joined my session and enjoy the rest of the day.